Okay. Good evening, everybody, and thank you and welcome to the first PERT Consortium and Education Committee from the PERT Consortium, their initiative on a very, very important topic, which is the post-PE clinic. As we all know, that there's a lot of focus of what happens to the patient during their hospitalization, the restratification, the diagnosis, and treatment. But really, what happens after discharge is increasingly where the outcomes, the quality of life, and patient experience really diverge. Persistent symptoms, their evaluation, so on and so forth, is so challenging and so important. Today's focus of the entire webinar is to talk about how to build this post-PE clinic. What are some of the nuances that exist across specialties, and really bring in a perspective from the variety of some national and international even point of views as to how things can be done. And it's really not a one-size-fit-all kind of a model. We are hoping for different perspectives and really for you to take something home and apply to wherever you are practicing to see where and how you can establish the post-PE care and care spectrum in your facility. So we'll get started. We have amazing panelists, and I will introduce them one by one as their conversations come along. To get us started, I have one of my PERT colleagues and friend, Steve, who's from critical care, and he's at UPenn. He's going to share his perspective of what to expect in RV recovery and some persistent symptoms and how to evaluate those. Over to you, Steve.
So my name is Steve Pugliese. Thanks, Sophia. I run a large post-PE clinic at Penn, and I'm going to give you just a quick overview of kind of my perspective of the post-PE clinic. And so, the first question is, why are these important? And they're important at different time points. And when we think about the different time points, the first time point after the hospital stay, I call short-term follow-up. And I think most of us would kind of describe this within the first 1 to 4 weeks post-discharge. This appointment may be one of the most important appointments, particularly to just assess to make sure the patient actually is compliant with the medication but has access to the medication. Those of us who've been doing this a long time know that, if you wait maybe 8 weeks or 3 months to see these patients, they show up to their clinic after their free 30-day supply of DOAC has run out. So it's really important to see them earlier. A lot of these patients have ongoing symptoms, and so we're addressing them, and they have all sorts of questions about resuming activity, travel, etc. And then the long-term aspect of this is really, I consider anything after 3 months. And this is where we're getting into what the cause of the clot is, what the duration of anticoagulation is going to be, potentially thrombophilia, workup in the appropriate patients, or age-appropriate cancer screening, deciding when the dose of the DOAC may need to be reduced, and of course, if they have ongoing symptoms, we're going to be looking for those. And then next slide, please. And then there's kind of the aspects that are really going to be important early on and long term. And so I would say one of the most important aspects is the education piece. Patients, particularly when they don't want to wait 3 months to really understand what's going on with their PE. And so that early visit, I think, is really helpful for education and kind of checking in with the patient psychosocially. We're obviously reassessing for bleeding at all the visits. And small things like whether they should be on antiplatelet medications and along with anticoagulation, how long that should last. Topics such as birth control, uterine bleeding, and any potential procedural interruptions and the timing of that. Next slide. So, as a pulmonary and critical care doc, you're going to hear today from a lot of different experts who have different perspectives on this. And this is kind of my perspective of how I did this. I've had a post-PE clinic since 2015. And I would say the most important aspect is that you can't do this alone. If you're not going to be successful to be the only person in your health system that sees a post-PE clinic. And so it's helpful to have a team, and that may be for our clinic. We have 4 or 5 pulmonologists who see these patients, but a lot of the post-PE clinics are multidisciplinary. And many post-PE clinics also work, as we're going to hear today, with APP and pharmacists to do that follow-up. The next aspect is particularly these patients that are post-hospital discharge. The no-show rate of these patients can be extremely high. And so it's really important to make follow-up easy for the patient, easy for the team. We've utilized things like Epic pools, direct phone numbers to our staff. We actually contact every single patient directly prior to scheduling in our clinic. We see them within 4 weeks. We make sure they have enough blood thinner to their appointment. If not, we write for it. And then we actually give them a reminder call a week before the important. So all these things are really patient focused to make things as easy as possible for patients. I think it's really important really to delineate what the goals of your clinic are going to be. For instance, you may determine as a pulmonary critical care doc that your focus is going to be, my follow-up is going to be really to evaluate persistent symptoms after a pulmonary embolism. If that's going to be the case, it may be fine to see that patient at 3 months, but as part of your program, you're really going to need to partner with another specialist, vascular medicine, hematology, et cetera, to make sure that patient gets early follow-up post-hospital discharge, and someone's going to manage the anticoagulation, et cetera. I think it's really important to have a standardized follow-up and time frame for patients. So all patients are really getting standardized time frame of follow-up. And then, one thing I think that's really helpful and something I learned early on is when you're creating your post-P clinic, it's important to kind of bake in value to that, because at some point as your practice continues to grow, you're going to probably want additional resources from your health system to help you support this clinic. And that may be something like tracking the downstream revenue, your patients. That may be quality metrics. Maybe you're showing that you're preventing readmissions, et cetera. Or like in our case, we tie our post-PE program to our CTEF program. And so there's a variety of ways to do this. And obviously your clinic is going to have to be unique to your health system. So I'm going to stop there, and I think I'm passing it off to Gino.
Yes.
So this is Gino Murley. He's a vascular medicine specialist at Jefferson, also in Philadelphia, and he's going to give you his perspective on post-PE care.
Good. Thank you, Steve. It's great to be here with this illustrious group of colleagues on this disease entity itself. So let's go to the first slide. And we looked at this as the low-risk patient. I'm sure we're going to talk about in another webinar. We'll be talking about the higher-risk patient population. This is the lower-risk group that Alex selected in terms of the process. So let's go to, this is the new guideline from the ACCHA. So let's go to the next slide to look at our model. So our model is a little different. We start in the ED since this is where this process begins. So our program is called JEF-FAST, Facilitated Anticoagulation for Safer Transitions. That's what FAST stands for. And it runs out of the emergency department since we have a close working relationship with the emergency room. If we look at this, we set everything up on Epic. So all the criteria for the ED, they don't even have to think about this. They go through the criteria, who has to be admitted, who has to be not admitted. And it's pretty straightforward. We realize the EDs are extremely busy, and we can't expect them to be like pondering stuff. They have to get to the process of the patient and manage them. So the patient is set up for discharge, and it goes into an in-basket in Epic, which goes right to the vascular center, and it's screened every day by one of our nurses or one of the secretaries. And the weekend, it's one of our nurse practitioners. They screen the in-basket for the patient. And we have a phone call within 72 hours of discharge. And that phone call, the purpose of that is to establish that they got their medicines, they're still taking it, and it's assumed they have a phone. If they don't have a phone, we rely on them coming back to see us if that's the case. If they don't have a phone, we give them a number, and I'll tell you how we work that with the city clinic. So there's a phone call, which is one of our metrics for the program. The next visit is 7 days. That's a second metric for our group, and they're seen by one of the members of the team or one of our APCs. So there's 5 members of the division and 2 APCs. There's 7 members. So the patients can be seen in 7 days. We measure that. So the reason they're there, they come back in 7 days, we make sure they're taking their medicines, they're doing well, they're not bleeding, or they may have questions. And then the issue is, do you need to work up anything after you see the patient? You know, what do you have to do at that point in time? And the patient leaves, and they're set up to come back in 3 months. Usually, if the primary is contacted and said, hey, look, we'll follow up on this patient, we will then contact the primary, set them up with the primary for the follow-up, so that transition of care takes place to the primary physician. If not, we will do that follow-up in the 3 months. And at that follow-up, we'll decide just what Steve was talking about. What are the other factors going on with this patient? Is malignancy a concern? Birth control use? Is there antiphospholipid antibody syndrome? Things that we would then have to address and get him to the appropriate specialist. The most challenging one I have is psych, because we do have a number of issues that do happen with the patients with anxiety from PE. And we have one psychiatrist we work pretty closely with. Fortunately, this doesn't happen a lot, but it's hard finding a good psychiatrist to help you out with the anxiety related to this disorder. So that's how our program works. In that top box there in the ED, they get, they're in the Pyxis machine in the emergency room. There is a 30-day supply of Eliquis or Xarelto. So we actually dispense from the ED. So they all go out with that, like Steve said. They get medicine education during the ED thing that's required. They get the 30-day supply. They get a phone number to call if they have a phone, and that's managed 7 days a week, 24 hours a day. And then if they need a consult in the ED, we'll provide consultation in the ED. That could be a teleconsultation if it's middle of the night, or during the daytime, it could be one of our physicians who goes down to see the patient. So that even helps a little more. Next slide. So I think I want to just highlight the fact that 3-day phone call is very important for us. It assumes the medication's been received, they're taking it, they have it correct. And I think that's an important, and the education is redone again with the patient. And then sometimes we have to secure meds for the next phase of care. And what we usually do is go through Medicare. If they have Medicare, Medicaid, how can we get the medication for the patient? Those that are homeless, uninsured, we use the Philadelphia Health District clinics, which, as Steve knows, in Philly is challenging to get them in, number one. But once we call them, we've set up a rapport with the physicians there. We can get the patients in, since they and get free care, of course. The key I highlighted again in bold here is that we're available 24 hours a day, 7 days a week for calls. And that's handled by the physicians, by the way. The APCs do not participate in that process. It's physician directed. So next slide.
Gino, can I interrupt? That's such an incredible way to take care of patients. How is this, like a call schedule 24/7 for
Yes.
physicians?
Oh,
Really
yes.
dedicated for this. This is
Yes.
incredible.
So when you're on PERT, you're on PERT for the week.
So this is not PERT. This is the post.
Yes, but this is
Incredible.
part of,
Okay.
yeah,
This is part of that PERT call. Okay.
yes, this is part of our PERT
Incredible.
call.
But
Yeah,
there was a question on the chat as well. So this is just a very robust and incredible two
Right.
examples that great. Thank you. Please continue.
So our metrics. So all of us heard Steve mention metrics. We got to have metrics. So we have 30-day readmission for bleeding or progression of disease. We measure the phone calls in 30 days. In the 3-day phone call that we have, we measure that the contact was established. And then we have the 7-day outpatient appointment that was followed up, that they get to the primary, where they transitioned to another physician, or they're seen in vascular mass. So this is what we measure in our process. Now, right now we have in the program 800 patients that have been enrolled in this program at 4 hospitals in the health system. And that includes our community hospitals, Abington and Torresdale, and then the Center City, 3 campuses in the Center City. What our purpose is not to admit people. That helps bed availability. And I think that's a real critical aspect now that beds are premium and the EDs are filled and they have to decant. So if you start looking at this and you're starting to have 800 less admissions, I know administrators look at that a little strangely. You know, the admissions are, quote, quick, easy in and out, but sometimes they're not. So I think we're saving here in a way of avoiding admissions to the hospital. What we found in the 800 patients we have on the data thus far is that DVT is probably the biggest reason you get discharged from the ED, unless it's up in the iliacs or the proximal femorals. Most of this is DVT, and a good percentage is low-risk pulmonary embolism. And so I think that's something you have to take into consideration. It's interesting. It's bleeding is not a reason for readmission. It's usually recurrent symptoms that brings the patient back to the ED to be reevaluated again. And they could have propagation of clot or another PE. Maybe the PE broke up and went peripherally, and now they have more flank pain. And they have what's supposed is to be new disease, and it's really the same disease. So I think when we think about this, it's a robust system, but it works well. But as you saw on the bottom, pulmonary is our main referrer. So just like Steve is the main guy, we have two main people in pulmonary that get all the pulmonary referrals, and then they have the criteria for follow-up of the patients for management. We use hematology if there's triple positivity or they have a rare disorder. We'll use hematology or malignancy, hem-onc, if we do find that we have malignancy during this time period. So the next slide is quickly. I just want to show you this. We just use these two things for our people who are managing the patient in the office. It gives them an idea about the drugs. I don't want to dwell on this. It's not important for us. And the next slide is dosing of the medication. We try to follow the guidelines. Next slide. We try to follow the guidelines on this in terms of dosing. This is our biggest thing about the weight of the patient, the biggest one. What do you do about people with BMIs greater than 40, or they're 120 kilos? That's always the biggest one. If you look at Rachel Rosofsky's article in American Journal of Medicine, it was actually a very good article to review, but we try to adhere to guidelines, and we're not doing levels on patients. And I think that's a chat, and the post-bariatric surgery, which is getting less and less, so we're not as worried about that as we were before. Low body weight sometimes happens, but it's the larger body weight that's most important. So I'm going to stop at that point. These are the key things for us. It's a little different model, and I'll be prepared for our next speaker, Milagros, who's going to be on right now, and I'll stop. Thank you.
Thank you so much. Milagros, over to you, and we can't wait to hear your perspective. She comes to us from Argentina. She practices as an internist and will share her perspective with us. Over to you, please.
Good evening. I'm Dr. Milagros Baez. I work at the Buenos Aires British Hospital in Argentina. I'm a specialist in internal medicine, and I just wanted to say that I work in a private hospital, which is a tertiary care level hospital. So maybe this is not the whole perspective of my whole country, but this is what we do at our hospital. Next slide, please. So we know, and we have been talking about this, that echo and CPET are suggested for CTEPH screening, and the guidelines recommend visit after PE 3 to 6 months. And we know that from the InShape study that CT findings and the index P can give us information for patients who may have CTEPH in the future. But the reality is not the same everywhere. We have been talking about this. There's no universally validated algorithm to follow up patients, and most of the patients sometimes get discharged without a structured follow-up plan. And in Argentina and Latin America, there is no validated local CTEPH screening algorithms. And we also know that indiscriminated echo or CPET for all patients, it's also no cost effective and strains limited resources. The next slide, please. So what we do at our hospital is I work with a pulmonologist at this clinic, and we have close referral with other specialties. We have an open door model that this is like all patients after an acute PE who are admitted or in the ED are invited to the to this clinic, to this specialized clinic, and the first visit is scheduled within the first week after the hospital discharge. And patients can come if they can come to a clinic even if they don't have a specific appointment. We give this information like when we have the clinic, that is 2 days a week for almost 3 to 4 hours. And the risk stratification starts in the clinic, not before. So we ask all specialists to send the patients to us. And then we start scheduling the follow-up 3, 6, and 12 months after that. And of course, only high risk and symptomatic patients get more procedures like echo, CPET, or right catheterization if it's needed. So our key philosophy is just to keep the clinic entry an open door for everybody. Next slide. So what we do at the clinic, me as an internal medicine, we try to do a comprehensive clinical assessment, and as you all said, evaluate persistence of symptoms and also investigate underlying causes when needed. We work alongside with the pulmonologists just to identify other overlapping conditions, and we talk to patients, and we give recommendations to them on physical activity and progressive mobilization, which is, as you said, one of the like more important things that people want to know when they can start doing their normal life again. And as I said, we have close connection with hematology, interventional cardiology, and cardiology, which they are not with us at the clinic, but we have a close connection with them just to manage the anticoagulation doses, if they need more monitoring, or if they need a thrombophilia screening, for example. And with the interventional cardiology, just to, they help us with the management of IVC filter retrieval, and also right heart catheterization when it's needed and when CTEPH is suspected. And we have a special cardiologist who has an expertise in echo. So he assesses the right heart function and pulmonary hypertension when needed. Next slide, please. So of course we have some barriers that we have to overcome. First, it was the clinic space and scheduling. We have to make ourselves, as Steve said, make us important and make ourselves value. We have to make the hospital understand why this was important and why we needed to follow up all these patients, and just to get some slots at the clinic and some time frame. We also have to raise awareness among our colleagues, especially in ED and hospitalists, because they are the first one who see the patients. And at the beginning of the clinic, of course, they were unaware that this existed and when they can send the patients. So we have to do some proactive reach out about that. We don't have the barrier about waiting list, because we just tell patients when they can come to us, and we just try to keep this going. And we're building our local evidence, because as I said, we don't have a global register about this in Argentina. So, I mean, the goal, I think, is not making it perfect from day one, but to start following these patients and keep this getting better. Next slide, please. So the impact in PERT, especially in CTEPH diagnosis, we have seen in our clinic that it has reduced the time for diagnosis, because now after PERT implementation, that is in my hospital was 4 years ago, we started following all the patients. In the past, we didn't follow all the patients, maybe just the ones that had symptoms, or when they already had been going through another clinics with this problem. We also have referrals from other hospitals. And of course, sometimes you have patients that cannot point out their index PE and they just come with the symptoms. Next slide, please. So I think that what matters the most is that CTEPH is underdiagnosed globally. This is not happening only in Argentina. But maybe this is a reflection about the absence of an organized follow-up clinic. So we think that the smart certification set resources, we have the index CT to use and see which patient will need more follow-up, or maybe close follow-up. You should start where you are. Steve has said that no person can do it alone, but someone has to start, and then you can start collaborating with other teams. And we also have our CTEF clinic together with this post-PE clinic follow-up clinic. And the open doors matters. So we don't have a system where we can call the patients. We are not enough in our team yet. So this open model that they can come and they know where we are, it's a great for us. Thank you.
Thank you so much, Milagro. That was incredible, and congratulations. Looks like you have a great approach to start somewhere and then improve and learn along the way, and you're already showing that you've made a difference. So this is really incredible. And thank you to the three panelists who've shared their structure and format. And we're going to move on to case presentation by one of our trainee council fellows. So Alex Fan, over to you. And then we do have additional panelists who are going to join. We have, I'm going to say the names correctly, Liban Tefera, Vascular Medicine, Cleveland Clinic. We have Dan Troja, Emergency Medicine, Advocate Health, North Carolina, and Vicky. Vicky is from Cornell Health, Michigan. So let's go over to the case, and then we'd love the engagement from the panelists. And please, from the audience, participate in the Q&A session. You have the chat available to you, and I can bring those questions forward to the panelists. So do engage in the conversation, and feel free to type in your questions, please. Over to you, Alex.
All right, wonderful. Thank you, everyone. My name's Alex Fan. I'm a pulmonary and critical care fellow over in California. Great talks by Steve, Gino, and Milagros just now. So hopefully this case will stimulate some discussion and provide us with some more perspective. So, patient, Miss AB is a 58-year-old female with a history of psoriasis on biologic therapy, history of an unprovoked deep venous thrombosis 5 years prior, who had completed previously 6 months of systemic anticoagulation, and also a prior splenectomy due to a traumatic motor vehicle accident. This patient presents due to 3 days of progressive dyspnea and exertion and pleuritic chest pain. She also reports mild left calf pain that started approximately 5 days ago and is associated with mild swelling. At baseline, she can walk 1 mile and climb 2 flights of stairs without any significant dyspnea. Some additional history for this patient. Social history, she denies any tobacco, alcohol, or illicit drug use. She is married, does not have children. She was recently laid off, however, previously worked an office job in tech. Also has recently lost health insurance due to the job situation I previously mentioned. And another factor is that she does live 3 hours away from the nearest tertiary care center. Like I said earlier, she did have a splenectomy due to a prior motor vehicle accident. Her family history is non-contributory to this case, and her medications are adalimumab and Tylenol as needed. So moving on to her objective findings, her vital signs, her heart rate is 110 beats per minute. Blood pressure is 128 over 76 millimeters of mercury. Respirations are at 22 respirations per minute. Her oxygen saturation is 93% on ambient air. And her BMI is 34 kilograms per meter squared. On physical exam, she is obese. There's no acute distress, appears at stated age. Her cardiovascular exam demonstrates tachycardia with a normal rhythm. Respirations are clear, no wheezing, and there's a little bit of tachypnea. GI, non-tender, nor organomegaly. Extremities are warm, well perfused. And then neurologically, she's alert and oriented to person, place, and situation. Workup-wise, a CT angio of the chest was performed, showing bilateral segmental and subsegmental pulmonary emboli with RV to LV ratio of 0.9. There is absence of contrast reflux into the IVC and hepatic veins. Bilateral lower extremity ultrasound was performed and demonstrates an acute left popliteal vein occlusive thrombosis. Labs, the high sensitivity troponin is 26. N-terminal pro-BNP is 120. The transthoracic echocardiogram demonstrates a normal left ventricular ejection fraction. Diastology is normal for age. Normal left atrial size. The TAPSE is 1.9 centimeters. The IVC measurement is 2 centimeters with over 50% respiratory variation. And tricuspid velocity, regurgitant velocity is 2. There's no septal flattening. Her risk stratification, her PESI score is 78. This is a class 2 low risk. Hestia is 0, low risk. Bova score is a 1, low risk. Per the previous ESC, this would categorize as an intermediate low risk pulmonary embolism, and the new updated AHA-ACC, this would be a classification of C1. Her treatment, she was started on apixaban at 10 milligrams twice daily for 7 days, followed by 5 milligrams twice daily thereafter. No interventions or procedures were performed during this hospital encounter. So I think, that was the case. Now moving on to our discussion questions. Is it okay if I go ahead and start with the first question for the panelists? Alrighty, so the first question is, does this patient require follow-up with a specialist, or would a primary care provider follow-up be sufficient?
Hey, Dan Troja here. I can take a stab at the first one. So, great case. It's a real case, and I think what's important here is that this is not a massive PE that had ton of subspecialists seeing this patient in the hospital. This is kind of a run-of-the-mill PE that's not perfectly well appearing, but is definitely one that I think specialist follow-up would be important. I think she has three things that are working against her. She has that recurrent unprovoked VTE. She has the post-traumatic asplenia, which we know is a relative thrombophilic state. And then her current PE, as you mentioned, with the DVT and the borderline positive troponin. The echo findings, while normal, the RV-LV ratio is borderline. And I think the decisions ahead, the duration of her anticoagulation and CTEPH screening at 3 to 6 months, and whether hematology should weigh in on her recurrence, aren't decisions that a primary care doctor should be expected to navigate alone, especially if she's in a more rural area. And frankly, I don't think we should ask the PCP to. But that said, the PCP has to be in the loop. And so they're going to be managing her overall health and her psoriasis and potentially her biologic therapy. And the model that has worked for us is that it's specialty-led follow-up with clean communication back to the PCP after each visit. And so the PCP isn't replaced, but they're informed and supported here.
And I can chip in as well.
Yeah.
Just from working at a large academic medical center in Ohio. So we have 26 different regional emergency departments that we work with within our post-PE clinic. And just naturally, some of those emergency departments are going to be farther away from the main campus of Cleveland Clinic. So we have patients that live 3 hours away that unfortunately just cannot make it to the specialty care. And so we provide a lot of our specialty care virtually. Like Gina mentioned, we see our patients typically within the first week of diagnosis of their PE, and that is a virtual visit with one of our APPs. And so, for this patient, it may be more easy for that patient to see a PCP that lives within local area, but we still are able to provide specialty care for that patient virtually, at least within the Cleveland Clinic system.
That's pretty interesting. Anybody else wants to share their perspective on a patient like this?
I'd like to make a comment about the agent she's using for her management of the psoriasis, the TNF inhibitor, adalimumab, Humira. And when you look at that, it does have an incidence of DVT in the post-marketing. So that's where we say, do we have to remove that agent, or you're protected? You're on apixaban for your management, so you're protected during that period of time. But that would be a decision to be made later on, subspecialty-wise, rheumatology in this case, to say maybe you want to remove that agent or change to a different class. But that would be made by a rheumatologist here. I always look at that. And then I was sort of fascinated by the motor vehicle accident, the splenectomy. Was that 5 years ago and the DVT occurred then, Alex? Or was that a separate entity, the motor vehicle accident and the splenectomy?
They are separate events. The DVT previously was unprovoked.
Yeah. So I was a little concerned, about the motor vehicle accident, splenectomy. Maybe they had a DVT after that. They didn't get prophylaxed, and made it. I would have a lot of thought process about unprovoked, because that unprovoked then raises the whole issue of working up the patient for hypercoagulability of some type of state for that. So I would keep that in mind in terms, and just like mentioned, I think Dan was great, in the sense of obesity, her age, I mean, a lot of risk factors there that maybe made a longer term and how to get to this. Just like at Cleveland Clinic, we have 35 EDs in our system, and some are as far, as 150 miles away from the main base. So we do use telehealth, like you said. It feels uncomfortable to me, but it's the only way we can deliver care and support to community and the ED physicians in those areas that we're working with. So keep that Humira in mind, the back of your mind about management,
Just
I
to
have
give
a
a shout out to the AHA-ACC guidelines that were recently published, there is a specialty clinic recommendation in there. So instead of had recurrent complex anticoagulation management questions and patients that have complex clinical presentations, there is a table with guidelines that really kind of lays out patients should be treated primarily by a PCP or which patients should be referred to a specialty clinic.
Thank you. I have a question from the audience that they're questioning about any program that the panelists are familiar with to support the patients, specifically regarding their anticoagulation if they cannot afford them themselves. Anybody works with a certain system or a format that you're aware of?
I could tell you we keep samples, but very strictly managed. The Joint Commission finds you with samples with not a system set up to monitor them. So we have samples of apixaban and rivaroxaban that we utilize to dispense as a dispensing pharmacy. We don't charge for it, of course.
I think we can utilize those because of the 30-day free trial offers from the DOAC companies. And we like to call them to-go packs and not samples, just it sounds a little nicer. But I think that the affordability, especially in this patient, is a real issue. And that's a real world issue. So the manufacturer of these medications do have assistance programs. I think that it's important to leverage your pharmacy teams from the inpatient side before the patient like this is discharged. So we don't send patients home with prescriptions that they can't fill. And so if you're building a program and you don't have pharmacy at the table, then I think that's a big miss. So definitely leverage your pharmacy colleagues. And then case management. That conversation also should start in the hospital, not at discharge, because I think the planning is extremely important there as well.
So I think the takeaway for the audience really is, Dan, that if they're thinking about establishing to get the conversations going on and involve those groups, pharmacy case manager earlier in the process, so they have a little bit of a buy-in. I'm curious to see what Vicky's experiences in the post-PE and how is the setup around you, how is the adherence and availability of medication decisions are taking place, and which specialty is involved.
So I definitely think it's important to have it addressed before the patient goes home. So one of the criteria for our low-risk discharge program is actually ensuring that the patient is able to obtain that prescription after discharge. So whether or not they have insurance and what their copay is, making sure that you're not just asking them, do you have prescription coverage, and then sending them with a trial pack. I see a lot of patients after discharge and somebody will go check the copay, tell them it's something, but then, they might qualify for coupons or a different pharmacy might fill it for a more affordable price. So a lot of these patients are coming to me and paying full price for the first month that they get after discharge. And I've realized that unless you actually address it before they go home, make sure they have the coupon in hand and actually know where they can get it filled, and what that copay is with the patient present instead of somebody just calling the pharmacy. It's super important. And for these patients, it's really overwhelming for them. So a lot of times I'll see them after discharge, and if there is any confusion or they paid full price, I'll have them pull out their prescription card and I'll show them or call while they're there to help figure out what their coverage is. And then if mail order's cheaper, if the coupons actually work, because that really is a huge issue and probably one of the biggest issues that I see after discharge. Sometimes it has to be adjusted. And for this patient specifically, if she just lost her job, making sure she can sign up for COBRA or that she'll have an additional plan in place, or at least knowing what she should do moving forward so that there'll be an anticoagulant on board, because if you don't ask them, they're going to be so overwhelmed. And you really have to put the extra effort in to make sure these patients have that support to get the prescription.
Very important points and just so prudent. I'm curious, anybody from the panelists have a setup where patients are able to go, which are obviously not as complex as this case with so many comorbidities, have a setup for the home care from ED, like discharge, and have that kind of a setup in place with a quick follow-up, availability of medication? Because it's encouraged. I know, the guidelines say that if they're kind of in the A category or the B category, we can think about that. Is there somebody who is doing that in practice right now?
We have a system in place where the uncomplicated low-risk DVT or PEs that meet ED discharge criteria are discharged, and we have this primary care nurse navigator that calls them within 72 hours with a call script, similar to Gino, and they schedule them with their primary care doctor unless they meet certain criteria like recurrent or unprovoked VTE. Those patients, then in addition to getting their PCP follow-up, we also schedule them with our post-PE vascular medicine clinic.
Yes, we also at our hospital, we have from the ED discharge for the patients that qualify, we give them a 7-day anticoagulation medication, and we send them to the clinic. As it's open door, they just send us with a note, and we'll see the patient and then just figure out what they have to do and who has to follow up that patient if it's low risk, and when we have to see that patient again.
Interesting. Yes, please go ahead, Lieben.
I'm curious if other panelists have had experience giving out real-time appointments, because one of the biggest struggles we've had is getting patients to answer their phones. We've had a lot of patients fall through the cracks because they didn't have a working number or didn't answer. And so we've tried to give out real-time appointments with variable success. And I was curious if other panelists have had success with that model, either from the ED or in the hospital.
I can tell you, Dan, we did give out the appointments, and just like you said, they didn't follow up. There was no number, no way to contact them. So I hate to say it failed, but it did.
Right.
And but it was the only way to try. And then our thing was, what do we do if we can't contact them? And they're out there with a 30-day supply of Xarelto or Eliquis, one of the drugs. And what do we do with those patients when we can't get them, especially the shelter ones? And that's the hardest part in Philly. You're going to have to contact the shelter, see who the director is, and see if the director could track down the patient. So my fear is the one patient population that I worry about the most is the uncontactable group for a variety of reasons. That's probably the biggest challenge. And you worry giving someone a month's worth of drug.
Right.
And you can't get them. I agree with you.
I'm curious, Milagros, how have you seen success or difficulties with the open door policy? Because that's so unique. And I'm really interested to hear about that.
Yes, I mean, we don't have the problem about contacting the patient because as it's a private hospital, everyone has an insurance just to get in. So we don't have that part, but it's of course a problem in Argentina, like in public hospitals. I mean, we are having, now that we're seeing all P patients, we have a lot of demand. So we're trying to make more hours and just divide our groups, like maybe 2 pulmonologists will be with me in one clinic, and then we have another clinic available for another small team, because patients just keep coming and we just tell them, okay, just come. We try to get them an appointment just for us to get everything organized, but sometimes we just want them to come and see, and if they have symptoms, like we tell them, okay, we have to see you in 3 months, but if you have anything in between, you can come. And sometimes they come and they ask you like, what do I have to do with anticoagulation? And we just then call the hematology. We don't have this problem because we have like private insurance, but the demand is overwhelming sometimes.
Mhm.
Yeah, what is your capture rate for patients that go home? Do most of them follow up with the open door policy?
Yes, I mean, in the last year, I would say like because I register all PE patients, and I will say that most of them just can come to our clinic, and I'll say like maybe I think we are losing maybe 10-15% of the patient, which is not very low, but we are keeping a good follow-up score.
That's pretty impressive. Alex, any particular question you want to tackle with the panelists from your nicely written? Some of them have been answered, I know. Any
Right.
particular one you want to tackle next?
Yeah. Yeah, I think a lot of these points have kind of touched upon a lot of these questions. I think one that I think hasn't really been expounded upon yet is the second one, who ensures adherence to therapy and makes the duration decisions? PCP, is it a specialist? Is there like a multi-specialty clinic? Just wanted to get the panel's thoughts on that.
So let me comment on multidisciplinary clinics. We tried it. It failed miserably because you can't build for everybody. So it's a great concept. And one person, when you come in, you just can't just go in there and you have a bunch of docs waiting around for patients. In the day and age we live here of productivity, you can't do that. So we have to have it very slimmed down and in terms of the patient and where to get them. So the decision, obviously, the primary care physician will say, when you see the patient, tell us the duration of anticoagulation, and we'll stop. And we tell them, I think this would be reasonable to stop in 3 months. Or if they say, would you like them to return to see us? We'll be glad to do that. Or we say, refer them to your local hem-onc doctor for further evaluation and consideration for duration, which gives them some options for that piece. I hate to say that, but I love the idea of multidisciplinary. It would be so wonderful. That is pie in the sky in the economic age we live in with insurance companies. And unless someone's being paid for, and you know how university hospitals are, they're like tight. So I think but idea the multidisciplinary clinic is a wonderful idea. It would work very well. It would be one stop for the patient, and then who you had there. But that's my bias about the process, my own.
I think where multi-specialty coordination comes in is before the patient comes to clinic. Obviously, PERTs are multi-specialty, but we have a VTE Center of Excellence, which consists of 5 physicians and support team of different specialties. And so we meet regularly to discuss how we want to approach certain cases. And there's constant communication between the 5 of us. And so a patient might see vascular medicine first, but if it's a difficult hematologic case with questions on duration or type of anticoagulation, then our hematologist colleague, who's part of the VTE Center of Excellence, gets pinged and then can see the patient quickly. So I think you're absolutely right that having this multi-specialist on the same day is difficult, but it doesn't mean you can't have multi-specialty input if you have a team ahead of time.
Awesome.
Great.
Actually, I do have a thought then, kind of like how tumor boards work for cancer patients, is there like a VTE board that could be happening in the outpatient setting? Obviously, we have the PERT inpatient. Just wanted to gather the panel's thoughts on that.
Yeah, for really tough cases that we do that, we'll meet and present cases. And it's not as complicated as some of the tumor board discussions. But certainly for some of these fringe cases where we're trying to decide on next steps, testing for CTEPH, referral, that's absolutely a model that can work for this case.
I agree. We do meet once a month, but we review really the real tough cases. The easy ones, I hate to say it, easy one. There's no easy case, but you're right. Once a month is good. It's run by interventional radiology, and so they do all the imaging and then they put together the discussion. I find it to be a very helpful case to review cases. I think Dan's right.
I think there's a pressing issue from the audience about contact with contacting the patient, how to make sure, because we are discussing the post-PE clinic, how to increase the show rate. So I'll go back to Steve and see what his opinions are as to the methodology. I know we spoke about 24/7 telephone calls, which is incredible, but I'm just impressed with that, but don't know how to apply it where I'm at. So what are some of the other methodologies, Steve, you can think about to have that show rate go up? Or what have you done?
So, so when I started at Penn in 17, I looked at my first 3 years for our post-PE follow-up, and just patients that were post-hospital discharge. Those are the most challenging patients. Our no-show rate was over 50%. And I looked the last 2 years, actually, it's been no-show rate has been 10%. So what we did a couple things. One is that what we found was happening is that patients were being scheduled appointments, and they were being given kind of random forms of communication, like a message in the portal or a text message, and you never even know if the patient received it. So we don't schedule any appointments unless there is some contact with the patient. Now you have to be creative. Like you said, they may not pick up your phone. So all of our admins use multiple lines of communication. They leave messages, they send text messages using Doximity where the patients can text back. And then once we get in touch with the patient, we then schedule them, and then we call them a week before the appointment. And that has really brought us down to the kind of 10% rate. The other thing too is that we've almost most patients will have like a family member to like an emergency contact. So if the patient is truly unreachable, maybe they have mental health issues or something like that, then we try to call that patient family contact. So that's what's worked for us.
Those are great points. And I just again acknowledge the challenges that we all face to even get the patient to the clinic so we can do what we need to do and make sure their health is restored. So I'm curious what Vicky thinks about the involvement of, the APPs from your perspective. What can the team do, and how can they support the process and growth? Because you're so involved, which is wonderful to see. What's your message there? Yeah.
I mean, there's been a lot of creative attempts. So, we've had the program for a while, and there's been a lot of different versions, but I think most recently I ask the patients when they come to clinic, about their experience. A lot of patients will come in and show me their after visit summary that was printed out with their medications and then their follow-up. And I found that a lot of patients would have their follow-up providers listed, but they'd have no idea why they were seeing the different specialties or who they were even seeing. They'd say, I saw this doctor inpatient. Why am I following up? I don't even know what the word hematology means. So for me, the best way to capture the patients, if I can get in their chart before their discharge, I mean, seeing every patient would be ideal because I can usually sell the clinic and then give them a print off of where it is, the dates of the clinic, why they need to come. But now I have a template that I actually put in their after visit summary. So I'll put follow up at the PE transition clinic, but I put a huge, very plain language summary about why it's important, why they're coming to see me. This is to make sure you understand your blood thinners. This is because of your blood clots. This is to answer questions and make sure that they're very clear on the importance of the visit. Because if my name or the PE transition clinic is one of 5 different providers and they don't know any of them but their primary, how do they choose? And when this is a new diagnosis, it's so overwhelming for the patients. I think just having somebody have ownership and be there to answer questions. I give them all my office phone number, let them know, I'm the safety net. So say after discharge, you have a question or don't know who to call or who to follow up with, or can't get your blood thinner, you can always call my office or email me. And a lot of patients do take me up on that, but I think explaining who they're following up with and why, and then making sure you have the process in place at the hospital. So for us, everything comes through Epic. We have tracking orders so I can actually see all the patients, so there's not missed discharges that we're not aware of. And if they are low risk discharge from the emergency room, I'm being notified for all those patients. We also have a separate ER physician and residents that are involved in the process. They get a specific text that the patient's going home, their MRN, and then they provide follow-up phone calls as well. But I think you have to be really creative about addressing why your patients might not be following up and how to get them into the clinic. And I think the best way is to ask them. And if you really communicate well with them before discharge, and then, if you see somebody's not following up or they cancel or no show for appointments, giving them a call and reaching out to see what's going on is helpful if you guys have the resources at your site.
Great points, Vicky. Thank you. That education piece is such a key to get them to buy in. And I think with that understanding, I think can be very invaluable. I'll go to Leben. Leben, what are some of the things you can think about to, kind of successfully have them come to clinic? What are some of the tools or metrics you think can be deployed?
I think Vicky hit on a lot of the big ones. In particular, our nurse practitioners are seeing these patients. They're the first point of contact before they're seeing the physicians. And they do an excellent job at expediting up expectations of what's going to be happening over the next 3, 6 months, 1 year, and really the importance of follow-up and what can happen if they don't follow up. So missed symptoms, wrong form of anticoagulation not being stopped. And so I think it's really important to set those expectations at the very beginning. So what we do that typically within our first week visit. And it gets to that last question that Alex printed out. How do you do that without overwhelming the patients? And our APPs do an excellent job of really meeting the patients where they're at and explaining that to the patient at a level that they can understand. And some patients are showing up actually excited for their follow-up visits because they do such an excellent job explaining to them what's going to be coming up in the next couple of months.
This has been such an incredible discussion, and I'm very sure we can really go on because just the value of the input and the challenges are just great to acknowledge. And maybe, Manasi, we need a, kind of a part 2 of this webinar to go into more in depth about the decisions actually that we have to make. But I think this is a series of webinars. So all the outpatient and the post-PE care will be addressed in these series of webinar, which is very beautifully developed conceptually by the education committee from the PERT Consortium. So we have about a minute. I would like for the panelists to think about somebody who wants to open a post-PE clinic, and I know you've highlighted some of the points, but that maybe a one-liner from each one of you to leave them with. What is the key aspect that you want them to have in their pocket when they're thinking about it conceptually? So, Gino, how about we start with you?
I think I would like to know what resources you have to work with to take care of the patient, and that could be different in each organization we talked about. I would want to know what resources.
Perfect. So take an intake from your facility. Okay.
Yes.
Dan, what do you think?
I'd say don't let perfect be the enemy of started. You don't have to make it perfect from day one. You just have to start. Patients are coming to you, whether you build it or not. The question is whether they come back to your clinic at week 2 or your ED at week 4.
That's very nicely said and very nicely put. Milagros.
I'll use one of the words that Vicky said, that is ownership. You have to, and like Dan said, you have to own the thing and just start doing it. And if you know who to call when you have like an issue or something, like, okay, I'm doing this, I'm taking this. And if I need to call the hematologist, I will call him, but I will take this patient and I'll take care of them.
Very nice. Lieben?
Try to meet the patient where they're at. I think Dan made a really good point there. It doesn't have to be perfect. Ideally, in an ideal world, you see the patient in a person, but if it's a telephone call, if it's a virtual visit, just try to meet the patient where they're at.
Very nice. Well said. Vicky?
I would say once you get started, continue to reevaluate how you can keep improving. I think addressing, and actually looking at the quality of care you're providing and what barriers you have, just always be trying to improve it because there's always ways you can help the patients more.
Perfect. Nicely said. And Steve?
It has to be easy for providers and patients. If they don't show up, if the patients don't come to your clinic, you can't help them. And so making a system as easy as possible to facilitate that transition of care is ultimately going to be the best.
Perfect. Nicely said. Alex, you want to add anything from your side of things or your case? Anything you want to conclude on?
No, I think at the end of the day, knowing the system that you work in, understanding what the limits are of the providers and the patient, and at the end of the day, practicing patient-centered care is what's going to lead to the best post-PE care for the patient.
I think that's a beautiful, beautiful line to close on. I thank you all, the panelists and everybody to be here, for bringing that beautiful case, Alex, and for everybody to join and have this opportunity to discuss. So valuable. So thank you, and everybody has a great evening. Wish you all. Yeah, bye-bye. Thank you. Thank
Thank
you
you.
for the audience to participate. Thank you.
Thank you.